Colorectal cancer is one of the most common cancers worldwide, particularly in the economically developed world. Large bowel obstruction caused by advanced colonic cancers occurs in 8 through 13% of colonic cancer patients. The management of this severe clinical condition remains controversial. Over the last decade, many articles have been published on the subject of colonic stenting for malignant colonic obstruction, including randomized controlled trials, RCTs, and systematic reviews. However, the definitive role of self-expandable metal stents, SEMS, in the treatment of malignant colonic obstruction has not yet been clarified. This evidence and consensus based on clinical guideline has been developed by the European Society of Gastrointestinal Endoscopy, ESGE, and endorsed by the American Society for Gastrointestinal Endoscopy, ASGE, to provide practical guidance regarding the use of SEMS in the treatment of malignant colonic obstruction. With the exception of one trial, all published RCTs on colonic stenting for malignant obstruction excluded rectal cancers, which were usually defined as within 8 to 10 centimeters of the anal verge, and colonic cancers proximal to the splendic flexure. Rectal stenting is often avoided because of the presumed association with complications such as pain, tenesmus, incontinence, and stent migration. Proximal colonic obstruction is generally managed with primary surgery, although there are no RCTs to support this assumption. Because of the aforementioned limitations, unless indicated otherwise, the recommendations in this guideline only apply to left-sided colon cancer arising from the rectosigmoid colon, sigmoid colon, descending colon, and splenic flexure, while excluding rectal cancers and those proximal to the splenic flexure, and other causes of colonic obstruction, including extracolonic obstruction.